Welcome back, Titans. Today we are talking about heart failure, what it is, how we're going to find our patients with their signs and symptoms, what's happening in that patient's body, and what's the best way we're going to treat this. So, you have to understand that heart failure is a general term that can mean any different part of the heart, and it can also mean the different pressures, a high pressure or low pressure system malfunction. Today, we're specifically going to be talking about left ventricular failure. Now, LVH, commonly known as what we would normally say as CHF, congestive heart failure, isn't always referred to as CHF. The C, meaning congestion, is usually when you auscultate the lungs and you hear congestion, but that's not always the case, as you may not hear it. So the general term is LVF, left ventricular failure. So, what is heart failure? So, heart failure occurs when the heart is unable to pump powerfully or fast enough to empty its chambers. When this happens, blood can back up in the systemic circuit or the pulmonary circuit or both. With LVF, left ventricular failure, we're concerned with the pulmonary circuit and blood backing back up into our lungs, but we'll get to that in a minute. So why does this happen? Why can somebody have heart failure? There's a number of different reasons, including coronary artery disease, chronic hypertension, diabetes, valvular heart disease, cardiomyopathy, dysrhythmias, and even some genetic conditions that they may have. These are all things that could preclude the heart failure as an illness itself. So, are there any risk factors associated? Of course, there's thyroid issues, alcohol, cocaine, or any other drugs that can cause damage to the myocardium. We remember from A&P that heart tissue is special because once the heart tissue is damaged and dies, it cannot rebuild itself like other muscles in the body. So once it's gone, it's gone. So we want to protect it and treat our patients the best we can to salvage as much of the heart as we can. So going back to LVF. So what is LVF? So Nancy Caroline describes LVF as regardless of its cause, heart failure produces symptoms in the most patients because the left ventricle does not pump blood effectively. When LVF occurs, blood backs up behind the left ventricle, causing a chain reaction. Blood builds up in the lungs because the left ventricle is unable to eject all of the blood within its walls. So, what is Nancy Caroline book saying there? So, we know we have a track from our left ventricle to our lungs. Now, concerning ejection fraction, so ejection fraction is the percentage of blood pumped out with each contraction. So say your ejection fraction is 60. That means that 60% of the ventricle blood that's inside the ventricle is able to be contracted and sent out effectively. When our ejection fraction drops, we have an issue. So with LVF, we have blood backing up into our lungs. So this is characterized by crackles in the lungs. When you're listening, we're going to start with our auscultation. We're going to listen to the apex and go down to our bases, or vice versa. And now you can hear fluid at the base of the lungs. Think of this like you're filling up a glass of water. With LVF, it's always going to start at the bases and then slowly fill up and work its way up to the apexes. If we have water way up at the apexes, this is extremist and we need to move rather quickly. So, how does this happen? What about signs and symptoms? So typically in your LVF patients, they could be hypo or hypertensive, but we're going to do an appropriate patient assessment. We're going to do our sample, our OPQRST, and really take a look at these patients. Typically, our heart rate is going to increase. Why does that increase? Because the heart is trying to compensate for the LVF, and now we're having poor gas exchange. So when we have poor gas exchange, our heart rates or respiratory rate's going to go up because we're trying to salvage as much oxygen as we can in a little bit of space we can. When you're considering the patient's lungs and the fluid backing back up, we talked about the glass of water. Now think about a bottle of water. If you had just, let's say, an inch of water left in the base of a water bottle, so no big deal. We still have a bunch of empty space. That's going to allow for the bronchioles and the alveoli to have somewhat decent gas exchange. If you turn that bottle to the side, that little 1 inch of water is now covering more surface area and causing less amount of gas exchange in the lungs. So that's why our patients, if you walk into a patient's house and they have CHFers have a bunch of pillows on their bed, they like to sleep semi-Fowlers because when they're laying supine, they have nocturnal dyspnea. They wake up in the middle of the night sweating and having shortness of breath because they're having poor gas exchange and they can't catch their breath. So we're gonna reposition our patients first thing, and we're gonna sit them up to try to get all that fluid back at the basis, so we have all this void space for gas exchange. What about our pulse ox? So our pulse ox is going to go down because we just said the gas exchange is poor and they could become hypoxic. Lung sounds, we're going to have crackles or rails. When you listen to this patient's lung sounds, it's going to sound, you're going to hear the blood in the lungs. It's going to sound like fluid, almost like somebody's blowing through a straw into a cup of water. It's going to sound wet. They could have a cough, and they could also have edema. So when LVF occurs, we need to look at the patient's extremities, mainly the left and right lower extremity. You can see what's called pedal edema. We're looking at the calves, the ankles, the feet, and this is all that fluid that's backing up into the interstitial spaces. If you put your thumb into the edema, it's called pitting edema, and there's 4 different grades of how you can measure until the skin returns to normal. So this is an obvious sign in our CHF patients. So how are we going to treat it? Well, we know we have fluid in the lungs, and they're having dyspnea and O2 sat dropping, hypertension, so we need to fix all that. So one of the most common ways to fix LVF is we're going to apply CPAP. So continuous positive air pressure mask. So what CPAP is going to do is provide that continuous pressure and try to force all that fluid back into the vasculature. This can also be used in conjunction with nitroglycerin, because we know that if we're trying to force water through a tube, we want nitroglycerin to vasodilate, and it's going to help that CPAP push it out easier. Now, obviously, anytime we do an intervention or provide a medication, we're also going to review our rights, and we're going to do a cross-check to make sure it's appropriate. Also for these patients, make sure we're monitoring continuously. We're going to check end-tidal CO2 waveform capnography and rule out any obstructive disease. If you do have some sort of obstructive disease like a bronchospasm from asthma COPD, you may need to consider adding inline nebulizer to your CPAP mask or doing that treatment prior to, depending on what your local protocols adhere to. So we've got our supplemental oxygen, considering CPAP and nitroglycerin. We're also going to put these patients on the monitor, do a 4-lead and a 12-lead, and we're going to track trend our patient and reassess frequently. You're going to want to listen to the lung sounds and notate where the rails were at. And after you began your process of CPAP, maybe we're titrating up. We're going to continuously listen to those lung sounds and see if our treatment is being effective. Now, keep in mind as clinicians, if you have a plan A, you have a plan B, you're always going to have a plan C. So we need to understand that if our treatment is not working, we may need to intubate these patients, just the way it is. So keep that in the back of your mind. Hope this was a good overview on left ventricular failure. I'll see you on the next one.